Hello, and thank you for joining me for a common medication presentation for home infusion staff by Katie Seacrest. I'm a home infusion nurse for Confluence Health, and I have been a nurse for 15 years, and I'm also a certified pediatric nurse. Methotrexate, common medication overview. Today we're going to review the classification, mechanism of action, indications, dosage administration, pharmacokinetics, side effects, monitoring, safety, and patient education. This should be about a 6-minute presentation. Introduction. How would you classify methotrexate? Let's take a quick poll. It's anonymous. I don't expect you to know the answer. Circle one answer and hand them in. I will have Ryan tally up the totals. There are actually two classifications. It's an immunomodulator and an antimetabolite, also known as an antifolate. Common uses, autoimmune diseases, and some cancers. Mythbuster, it is not an immunosuppressant. Mechanism of action. It's used to treat autoimmune diseases and cancers. It modulates the immune system by blocking replication of immune cells. It targets inflammatory pathway cells by inhibiting rapid cell division and modulating immune response. It's used for maintenance therapy in autoimmune diseases and reduces inflammation. It's also used as a dual therapy with a biologic to prevent antibody formation. It does interfere with the folate metabolism. Key takeaway, it's recommended to take folic acid supplement while on methotrexate. Let's find out why. More about folate. Methotrexate and mouth ulcers. The medication inhibits DHR, dihydrofolate reductase, an enzyme necessary for DNA synthesis and repair, leading to depletion of folate in the body. The depletion can result in oral mucositis, a condition characterized by painful mouth ulcers. To mitigate these side effects, folic acid supplementation is recommended. It helps maintain the necessary levels of folate and can prevent the development of mouth ulcers. Key takeaway, it is recommended to take folic acid the day after methotrexate to minimize side effects. It is indicated for many autoimmune diseases that we see in our patients, including atopic dermatitis, eczema, moderate to severe, Crohn's disease, moderate to severe, dermatomyositis, eosinophilic granulomatosis with polyangiitis, granulomatosis with polyangiitis, and microscopic polyangiitis, lupus, psoriasis, psoriatic arthritis, rheumatoid arthritis, sarcoidosis, systemic sclerosis, also known as scleroderma, and morphea, localized scleroderma. Key takeaway. Methotrexate is not a quick-acting drug. It takes about 3 months, roughly, for methotrexate to take effect. So if the patient is feeling like methotrexate is not helping or working, the doctor may encourage them to stay on it for 3 months to see how they feel. Dosage and administration. For immune modulation, it is taken in low doses and infrequently. This is commonly what our patient population, how our patient population would use it. Low dose is 2.5 milligrams, and one of our patients is taking 4 tablets, which is 10 milligrams weekly. The high dose protocols are used for cancer. We won't get into this too deep, but it's a 1,000 milligram once dose followed by a leucovorin rescue. And Ben can explain that more, but the high-dose protocols of methotrexate can be fatal, and that's why they do the leucovorin rescue right afterward. Pharmacokinetics. Absorption, it has good oral bioavailability. If a patient is not tolerating it orally, though, they can do it via injection. And we actually, when I worked on pediatrics, we had a patient who was receiving the injection weekly because she was so nauseous with it, and she actually had a feeding tube in, and so after the mother would give it, she would vomit, and she tolerated it better via injection. It's widely distributed and it accumulates in tissues, and it's eliminated by the kidneys. Key takeaway, remind and encourage patients to get their labs done in the frequency the doctor has ordered. Ensuring lab compliance helps monitor kidney and liver function. Side effects. The most common are nausea and fatigue, and patients describe the fatigue as they just want to lay around in bed all day. There are more serious side effects, including hepatotoxicity. You can also have bone marrow suppression and pulmonary toxicity, like interstitial pneumonitis, a dry cough and shortness of breath, or you can have gastrointestinal, more nausea, vomiting, and mucositis. Monitoring include regular blood tests like a CBC and a CMP. That CMP will include the kidney and liver function. Key takeaway, continue to educate patients on toxicity signs like mouth sores, cough, fatigue. Thank you for listening. Do you have any questions?